David. First of all, I would like to thank Dr. David Wilson and Axel Grothy for the kind invitation. So basically what I have been asked today is to give a flavor in 20 minutes of what is going on in taking therapeutic decisions in patients with colorectal cancer based on the molecular subtyping that we may have in the next future. So you all know this slide. So this is a summary slide of what we have achieved during the last, let's say, 20 years in the treatment of colorectal cancer. Basically, we have achieved new cytotoxic agents in the clinics, also some targeted agents directed to both the VEGF pathway and the EGFR pathway, improving actually survival, as it has been mentioned before today, up to an outstanding 30 months median survival in patients with metastatic colorectal cancer. Nevertheless, the way that we have developed these drugs has been almost completely empirical. So there was not a huge definition on which are the subtypes of patients with colorectal cancer that could derive more benefit from one particular agent, including cytotoxic agents or the targeted agents. So things have to move forward in a different way, we hope, at least for the new drugs that are being developed in other tumor types, not in colorectal cancer. So basically, I'm going to base my talk in 3 different topics. So the first one is the molecular determinants that we have demonstrated that are determinants for primary or secondary resistance to EGFR inhibitors. The second one is going to come more to the discussion of the talk, the unsupervised genotyping of colorectal cancer and how this is being implemented in colorectal cancer in the clinical setting. And finally, I'm going to give some messages for 2 well-defined populations. The BRAF mutant, that actually has been addressed before by Stan Koppett, so I'm not going to expand on that, but also the RAS mutant population that actually is the most frequent in colorectal cancer, accounting for 55% of the patients. So basically, moving to the first topic, you all know the EGFR pathway. We had a lot of expectations at the beginning because EGFR expression is widely present in patients with colorectal cancer, but unfortunately, we also know that there are important downstream effector protein mutations that could prevent activity for these EGFR inhibitors, including cetuximab or panitumumab. And actually, lots of new compounds targeting these downstream proteins, including RAF inhibitors, MEK inhibitors, even initially RAS inhibitors or ERK inhibitors have been combined with EGFR inhibitors in order to prevent these secondary or primary mechanisms of resistance. And when we talk about mechanisms of resistance, in looking at the references that we have right now, patients that are EGFR naive, so patients that have not received any EGFR inhibitor, if they are treated with single agent EGFR inhibitors, actually the response rate is very low, let's say around 15%. The reason for that is basically because some patients actually have mutations in these downstream proteins, as I mentioned before, KRAS, NRAS, BRAF, but also some others that also prevent or reduce the activity of EGFR inhibitors, including PIK3K mutations. Also, there are patients that have combinations of these mutations at the beginning, and also we have some patients that have amplifications in some genes that actually Dr. Wilson mentioned before also for gastric cancer, like c-MET or HER2 from the early beginning, even KRAS amplification. So this is the map or the figures that we have of patients that are EGFR naive. But once these patients, those that are wild type, have been treated with EGFR inhibitors, actually there is a selection of clones that are present from the early beginning that rise up producing secondary resistance. And this slide actually summarizes how a patient that initially is all RAS wild type or even PIK3K wild type when the patient is treated with an EGFR inhibitor, there is an increasing number of clones that appear bearing KRAS mutations and RAS mutations, c-MET amplification, HER2 amplification, among others mechanisms of secondary resistance. So at the end, this is a slide provided by Alberto Bardelli. You can see that with summing up the data coming from biopsies of patients that have been treated with EGFR inhibitors, even also taking blood samples for circulating free tumor DNA, you can see that the amount of patients that actually, for example, bear HER2 amplifications or MET amplifications goes up to 10%. So remember from the previous slide, it was only 2%, 3% in patients that are naive, up to 10% of the patients when they have been treated with EGFR inhibitors. Obviously, all these markers are negative biomarkers or are negative predictors of activity. But this is what we have at least for EGFR inhibitors. And at the end, you can end with a list like this when you have a number of potential biomarkers that may be addressed in the clinical setting, what we call on-off biomarkers, so either mutations or amplifications that can we evaluate in patients with colorectal cancer, but also there are some others more related to the expression of proteins like the ligands, very difficult to validate, very difficult to establish a definitive cutoff, and although that in scientific experiments provide us information on patients that may be also resistant to the treatments, this is not something that we are going to use in the clinics. So that's what we have for EGFR inhibitors. Moving forward to the unsupervised genotyping of colorectal cancer, actually the first seminal data that came to us was the data from the TCGA. And as you can see in this initial study, evaluating more than 200 samples of tumors and normal tissues, we could divide at least the population of patients with metastatic colorectal cancer in two big groups, what we call hypermutated and non-hypermutated. 15% of them hypermutated, around 85% of them non-hypermutated. And when we say hypermutated or not hypermutated in colorectal cancer, we have to put this in perspective, because if you look at the data of all the tumors that have been evaluated by the TCGA, you can see that patients with colorectal cancer actually have, most of them, a huge load of mutations. Obviously, some of them are more hypermutated than the others, but when you compare this with other tumor types, we are in the range of hypermutated. Nevertheless, in looking also at this classification, hypermutated, in here we see the genes that we expect with, for this, especially MSI population, so mutations in APC, in TGF-beta receptor, and in BRAF. On the contrary, in the non-hypermutated population, we see mutations in the genes that are well described in colorectal cancer, like APC again, TP53, KRAS, PIK3CA, and others. So this was the first approach to divide patients in colorectal cancer, and thanks to this data from the TCGA, we were able to split two different populations, right? So the hypermutated, more in the right side, usually microsatellite unstable tumors, hypermethylated tumors, and obviously chromosome stable, accounting 15% of them, and those more in the left side, these are chromosome unstable tumors. Some of them actually have KRAS mutations, and they are not hypermethylated. So this was the first approach that was published. Later on, several different groups started doing gene expression studies in samples of patients with colorectal cancer. This is a study that we participated, but there are some others, as you will see. Basically, in here, in this particular study, we were able to differentiate patients in three different categories. So the first one, what we call A-type, this is the MSI population with BRAF mutations accounting for 20% of the patients. The second one was the so-called proliferative epithelial with a lower number of mutations, and these tumors were MSS, so microsatellite stable. And finally, a third group that was what we call the mesenchymal. And this is really very constant between the different groups. The first thing that you can see here is that there is a prognostic information. So basically, even these patients being in stage 2 and 3, you can see that there is a prognostic information. And you can see that in this particular series, those patients that had the MSI subtype, as suspected, did better than the others. This was the first information. The second information that we could have from these patients is that actually, related to these subtypes, we can show some better or worse benefit from the addition of adjuvant chemotherapy. And this is the case for the group of MSI and also for the MSS population, but not for the mesenchymal. The mesenchymal do not respond. And when we try to understand why is the reason for these clinical differences, basically what we saw here is different in the expression of the genes. For example, the MSI, the mesenchymal subtype, the so-called C-type, actually have high expression of genes that are related to mesenchymal properties. For example, TGF-beta receptor, ADCL also expression, and on the contrary, low expression of those genes that are more related to an epithelial phenotype, like, for example, c-MET or EGFR. And actually, this was the opposite, for example, in the B-type. So you can see in the B-type that there is a higher expression of MET and EGFR, for example. So another implication that actually this gene expression analysis has, as you can see here, those patients with a type A and type B, those that benefit from adjuvant chemotherapy, you can see that have a higher expression of genes that are related to proliferation, like aurora kinase A and Ki67. Perhaps this demonstrating that these patients could actually benefit from adjuvant chemotherapy. At the end, what anyone wants with an approach like this is to provide classification that could provide information for us in order to take decisions on treating these patients in the adjuvant setting, with different chemotherapy schedules, or even with targeted agents, if this was the case. And obviously, you can correlate this gene expression analysis with the most common mutations that we can see in the clinical setting. So when this analysis was done, actually, several other groups did the same work. And you can see in this nightmare slide an example of different groups that look at patients with valid tumor specimens for gene expression and correlating this expression with survival. And basically, from this nightmare, you may think that there are multiple signatures. Actually, you can see that in these different signatures, there are some groups that provide 3 different subtypes, some others provide 6 different subtypes. You may think that this is really discordant at all, completely nightmare. Even we have to realize that most of these samples came from stage 2 and stage 3. So actually what Rodrigo Dienzman led 2 years ago, from the information of all these different signatures coming from different groups, is to try to identify a colorectal cancer subtyping consensus defining subpopulations of patients that were comparable between the different signatures. And this is what was done with the collaboration of all these different institutions, compiling all the information from these samples. As you can see here in this slide, this is a summary slide on the populations of patients that were included. Basically, you can see that they come from different sources. Some of them are public, some of them are proprietary. Some of them come from platforms that are really well validated, like, for example, Affymetrix or Agilent. Some others come from other least frequent use, like the ALMAC platform. Even the source of the tissue, like fresh frozen FPP, so that produces really robustness to the analysis because the samples come from different places. In considering the clinical characteristics, as I mentioned before, perhaps the caveat that we have is that most of the patients actually had stage 2 and stage 3. So there are very few patients with stage 4, although right now there is a huge effort to recover patients and samples from stage 4. And the initial data that we have is that the data with more patients with stage 4 is still comparable. So to make this brief, actually what the investigators did is to put in together all these different patients from the different series and try to converge with one unique classification with 4 different subtypes. You can see here the subtypes, MSI or immune, the mesenchymal, the canonical, and the metabolic. And now we will describe a little bit how these different subtypes work. Basically, the first thing that we have to relate is some clinical characteristics of these subtypes. For example, the MSI immune subtype, accounting for around 13% of the patients, the median age is a little bit higher compared to the others, and on the contrary, the mesenchymal subtype, number 4, the median age is a little bit lower. The gender distribution, most of the patients are male, except for the MSI population, where we have more females as expected. And finally, for the clinical stage, as expected also for the MSI population, we have very few patients with stage 4, and on the contrary, for the mesenchymal population, we had more patients in stage 4. Also, the site is important. As I briefly introduced, we all know that the MSI patients are more located in the right side, whereas the others are equally, more or less, equally distributed, except for patients with CMS number 3 that were also located more in the right side. And for the MSI status as expected, this is something that is more particular for the first subtype, the MSI or immune. Also, the levels of mutations, I didn't mention this before. The MSI population, the immune population is the one that has the higher load of mutations compared to the other. And opposite to this, when we look at the copy number alterations, actually the other subtypes have a higher number of copy number alterations compared to the first one. When looking at the mutations, as expected, most patients with BRAF mutations were in the first group, the MSI or immune, and KRAS mutations were present in all the groups, but especially in the CMS3 group, that is the so-called metabolic group. Also, with some of these series, we were able to look at the data of protein expression by RPPR, especially the data coming from TCGA. And as you can see here, there are differences in the expression of the proteins related to the pathway activation in the different subtypes. Finally, integrating all this data, you can come to a selection of properties of these different subtypes. For example, the MSI or immune, as mentioned, we have immune activation, immunal filtration, as a main characteristics. For the number 2, this is the canonical. You can see here that we have canonical activation of the Wnt and the MYC pathways that are important in colorectal cancer. The third one, the so-called metabolic, more metabolic characteristics at the phenotypic level. And finally, the mesenchymal one, as you can see, this is a subgroup highly correlated with mesenchymal activation, angiogenesis, also TGF-beta activation. So basically, as a summary, you have a table like this when you can compile all the clinical characteristics and all the genotypic characteristics. So just to summarize, with the MSI immune, we have seen that these tumors are more located in the right side. They have hypermutations. They have also mutations on BRAF and immune activation. The canonical, distributed both in the right and the left side. This population has a high chromosomal stability, and therefore they are microsatellite stable and with Wnt and MYC activation. Metabolic group, this is the third one. This is more heterogeneous at the chromosomal level with KRAS mutations and metabolic reprogramming characteristics. And finally, the mesenchymal one, more located in the left side and in the rectum, high chromosomal instability, TGF-beta receptor activation, as was mentioned before, stroma activation and angiogenesis activation. So this actually offers us opportunities for developing new drugs in these particular subtypes. For example, in the MSI population, this is a population where we have seen actually that immune checkpoint inhibitors do quite well compared to the others. So in here also, some immune regulator drugs can be administered, and obviously the BRAF combination strategies that have been mentioned before. On the contrary, for the mesenchymal population, this is probably the best population that we have to test drugs like TGF-beta receptor inhibitors and also new anti-angiogenic compounds and new matrix inhibitors. Finally, perhaps the subtypes that we still don't have much information on how to develop new drugs are the canonical and the metabolic, where we don't have even drugs that are widely accepted at the preclinical level to evaluate in this setting. One final thing about this subtyping effort is that obviously this has also prognostic information, as I mentioned before. For overall survival, you can see that the different subtypes have different behavior. Obviously, the worst one is the mesenchymal. The same for disease-free survival. And on the contrary, when these patients relapse, and this is well known, the subtype that actually do worse is the MSI subtype. We do know that when these patients with BRAF mutations relapse in the adjuvant setting, actually the prognosis is very poor. So you will see the publication in the next future. This is going to be really a seminal, an outstanding publication on how colorectal cancer is going to be divided in the next future. Finally, I'm going to talk a few slides only on the BRAF and the RAS mutant populations. I'm going to skip the BRAF because this has been mentioned before. Perhaps the important point here is that in this population with BRAF mutations, we have right now clinical trials showing combination approaches of BRAF inhibitors plus EGFR inhibitors, where we can see response rates ranging from 20% up to 40% in this very poor risk population. For the RAS mutant population, and again, this is the most frequent population that we have in colorectal cancer, we know that these patients are refractory to EGFR inhibitors, and we still don't know which is the best way to treat these patients. There are several preclinical studies that raise a hypothesis on how, when we have tumors with RAS mutations and we treat these tumors with a MEK inhibitor, we may have immediate upregulation of receptors like it was in the case of the BRAF population. In this particular case, the data shows that the most intriguing candidate may be members of the HER family receptor, especially HER3, but also the insulin-like growth factor receptor. I have to tell you that the preclinical data is less robust than in the BRAF mutant population, but still there are several clinical trials that are actually designed to target this population of patients with KRAS mutations with combinatorial approaches of MEK inhibitors plus EGFR inhibitors or HER3 inhibitors, as you can see in this slide. So at least we'll be able to see whether with this approach we see an advantage in this setting. Finally, this is my final slide. I hope I have been able to show you that there is a new approach to do new clinical trials in patients with colorectal cancer, basically in looking at the molecular characteristics, in looking at these subtypes that have been defined by the colorectal cancer consensus group. These 4 different subtypes obviously have different biological properties. They also have different clinical and molecular properties, and we expect that this is going to provide fruitful information in the next future to do clinical trials in this setting. Nevertheless, what is really very important is try to do clinical trials based on strong science, sound, rational, as is this the case for the BRAF mutant population. We don't have some other populations with this strong rationale. And finally, as you have seen, especially with the initial data on the EGFR inhibitors, we know that the expression of genes, it's going to be quite constant over time. But nevertheless, we always can pick up populations of patients, or populations of cells that may be resistant to treatments that have been administered before. And for this, it's really very important to understand that we should look at the disease in a very dynamic way, especially taking information from tools like the circulating tumor DNA that probably is going to provide information on this dynamic approach. Thank you very much, and I'm happy to answer any question.